Good afternoon, everyone. My name is Siobhan Nelson, and I have the honour of serving as the President-elect of the Academy of Health Sciences. I'm excited to welcome you today to the second episode of our dialogue series. This is a series of informal Academy-led conversations on a wide range of topics, from new frontiers in science to current issues in healthcare. This series is open to fellows and non-fellows. The intent is also to increase understanding of the health sciences, and through this, increase general trust in science. Prior to moving forward, although we come to, I apologize. Siri has interrupted me. Prior to moving forward, although we come together today from across the country, I would like to recognise that the office of the Canadian Academy of Health Sciences is in Ottawa, and as such, it is located on the unceded and unsurrendered Algonquin and Anishinaabe territory, whose presence there reaches back time immemorial. We recognise the role of the Anishinaabe Algonquin Nation as the customary keepers and defenders of the Ottawa River watershed and its tributaries. This dialogue series is an initiative that will showcase the wealth of knowledge and reach of our Academy. I hope you will become part of a regular audience for these events as we engage with topics of national and global importance in the health sciences. We are pleased to be doing these events in partnership with Desjardins. Desjardins is the Academy's bank, and they've graciously provided us with the financial contribution, which enables us to keep these series free of charge. Now, for today's dialogue, it's my great pleasure to introduce the Canadian Academy of Health Sciences past president, Dr. Paul Allison. Dr. Allison is professor in the Faculty of Dentistry at McGill University. We've been very pleased that Paul has served on our board of directors for the past 3 years. And just before we begin, a few housekeeping notes. The chat bar will not be active for attendees, but you are welcome to ask your questions using the Q&A button located at the bottom of the Zoom window. So I'll hand it over to you now, Paul. Thank you.
Thank you very much. Thanks very much for that introduction, Siobhan. And it's my great pleasure today to be moderating this session with Dr. Patricia Ocampo. Dr. Ocampo is a professor of public health at the Dalla Lana School of Public Health at the University of Toronto. And she is a Canada Research Chair in Population Health Intervention Research. She's a social epidemiologist with a 30-year record of scholarship in urban health. Dr. Ocampo's research focuses on upstream determinants of health and specializes in measuring the impacts of urban structural issues and social programs. As an innovator, she has advanced theory about urban health and expanded the knowledge base on community-based solutions to urban health inequities. Her approach relies on creating strong partnerships with affected communities to advance understanding of and co-designing effective solutions to urban challenges. She considers herself fortunate to have lived in a variety of exciting cities, such as Tokyo, the San Francisco Bay Area, the Baltimore-Washington corridor, and most recently, for the last decade and a half, in Toronto. Her work has been widely recognized through various local, national, and international awards, and she is a fellow of both the Canadian Academy of Health Sciences and the Royal Society of Canada. Patricia, we're so pleased to welcome you to this Canadian Academy of Health Sciences dialogue series.
Thank you. I'm glad to be here.
Great. Okay. So let's get going with the first question then. You're an expert in the field of urban health. But what is urban health and how does it differ from, for instance, suburban health or rural and remote health?
Well, urban health is the study of how features of cities and social and economic and political processes within cities shape the health and well-being of those who live, work, and study in cities. Ideally, it's approached from a multidisciplinary perspective, as no single discipline can capture it all. Admittedly, public health contributes a large proportion of the research on urban health, and there are benefits and drawbacks of a public health approach to the study of urban health. For example, because public health tends to rely on biomedical theories and data at the individual level, there tends to be a focus on what individuals are doing and how they are impacted by their own individual behaviors like lifestyle and exposures. So much of what impacts well-being actually happens upstream, such as policies or even globalization that impacts urban environments. And in those instances, maybe sociology or political science might be better at revealing impacts on urban health, thus the need for multiple disciplinary perspectives.
Okay, so and why focus on if you want this geographical element, if I'm using the right phraseology, the urban versus suburban or rural and remote?
Yeah, so the determinants of urban and suburban and rural remote health are actually quite similar. All individuals need their basic needs met. We need food, shelter, income or resources to meet those basic needs and more. And the factors or processes or opportunities that enable these basic needs to be met or for individuals to survive and thrive differ in urban versus suburban or rural areas in terms of, the proportion at which they're there. If we only cared about understanding the determinants of health, maybe we wouldn't need to differentiate as much between these geographic areas. However, since we want our research to make a difference, we are more likely to be interested in the solutions to improve poor health. And the possibilities for interventions do differ across those three environments and do require, therefore, a separate consideration of how those solutions would work in those different geographic areas.
Right.
Compared to suburban and rural areas, we tend to think of cities as places where there are more resources and maybe the standard of living is better. Certainly more people are moving from rural areas to cities, and that places new challenges on both, rural and urban areas that impact the health and well-being of the populations that live there.
So then, can you just exploring this this idea of the different sort of geographical settings a bit further? Can you sort of give us some examples and explain a little bit more? For instance, what's the health of and the health issues faced by people living in central Toronto compared to, for instance, Kuujjuaq?
Yeah, I think because there would be differences in resources, for example, opportunities to get healthcare, opportunities to get education for all children, because those opportunities differ, that is, in rural and remote areas, there are fewer resources there. And because it's more expensive, there's a whole host of reasons why, political will. The opportunities to get access to the resources that will maintain good health, improve health, or get better from health conditions do differ because of the difference in resources. So that would be something that we would have to consider when we're thinking about the difference.
Do we, maybe it's too big to generalize in this way, but do we see any particular differences in the health status, if you want, of people living in these different geographic regions?
Yes. So for example, in rural and remote areas, you're going to have more challenges with food security.
Right.
Again, there's a whole host of reasons for that. Some of it is the availability of food in remote areas. And then also something that we call lifestyle factors. So in a place like Toronto, you're going to see more opportunities for people to be active, whether it's they can bicycle to work or take a more active approach to their transportation, whereas in suburban areas or even remote areas, you need a car to get around. And so you might have less physical activity. So your lifestyle might differ, for example, and those impact health. Both food security and level of physical activity absolutely impacts health.
Okay, great. So how does the physical environment interact with social and cultural phenomena to determine health, but also another area your concentration of your work is in health inequities and inequalities? So how does the physical environment interact with social and cultural phenomena to determine health and inequalities?
Yeah, I guess the first point to make is that the physical environment and the social institutions and processes and culture are all determinants of health and well-being, and they also contribute to the production of inequities. And I like where you're going with this because you're already illustrating some of the challenges to understanding and studying urban health. The physical environment alone has many dimensions, operating at many levels. For example, you could think about a park in a neighborhood, or the type of housing that we live in, or whether or not we live near green spaces. It could be about how an area is zoned and so on. And so we can't consider the physical environment just one characteristic or feature of the urban environment. And the same can be said of the social environment. It's multidimensional and it's multi-level, not to mention potentially changing over time, as is the cultural environment. In some ways, the combinations are infinite, which can make the study of urban health challenging, and the accumulation of knowledge about any given dimension very difficult if we're not intentional about how we approach the topic. Let me just give you a small example. Early on in my career, I studied how features of neighborhoods impacted well-being. And as the field began to grow, many other scientists joined in to study this topic. And one issue we were interested in is how crime might impact health. But each study measured neighborhood crime in a different way. So some measured events. They counted the number of crimes in a neighborhood. Some looked at density. So they would look at number of crimes per square kilometer. Others still measured crime differently, for example, per capita crime. So they based it on population size. So we all had varied data on whether and how neighborhood crime was related to health and well-being. So when we try and do the systematic review and combine knowledge from those studies on how neighborhood crime impacts health, it's hard to compare and combine data from those studies that use different measures of crime. And that's just one example of some of the challenges that we face as a field to try and accumulate knowledge about urban environments and health. But getting back to your question, in terms of how the physical and social and cultural environment are related to inequities, for example. You know, the central idea behind how inequities are produced or manufactured is that they're caused by an unequal distribution of power, resources, and wealth. And so when the physical, social, and cultural dimensions of urban environments come together to give groups or individuals more access to income and power and resources and wealth, those individuals will be among those, the haves, you know? And then for the groups who are deprived of those resources due to the interaction of those same dimensions of the urban environment, they're among the have-nots. So the distribution is not random, but rather is by design. Those with power use their influence to keep hold of the access to the levers in the system that enable them to hold on to power and to bring even more resources and wealth their way. including the means to extract resources and wealth from others. And for those without power and resources, they struggle about how to gain access to those. So unfortunately, we can see from the decades of data on the patterns of urban inequalities that the wealthy have been far more successful in this struggle than those with that are either in the middle or at the bottom.
Building on that discussion, I have the impression that there's more and more awareness in the media and in the political debate around the impact of our urban environment on well-being in society. There's much more debate, I think, than there was even 10, 15 years ago around, green spaces and, as you say, facilitating things like bicycle paths, parks, are there appropriate schools, all that sort of thing. To what extent do you think that local groups, local areas are beginning to take back some level of control over their physical and the broader environment in which they live? Or is that still very much something which is controlled at the sort of powerful municipal level and the provincial level certainly in Canada anyway?
Yeah, I think there is a lot of variability, especially in large cities at the neighborhood level. And you're right to point out that residents care about where they live and they advocate for resources that they need. Even governments recognize that there are some neighborhoods that require greater attention and they put greater investments in those neighborhoods. It's been shown to work better when residents are involved in advocating on their own behalf for what they need in their neighborhoods as they know best. Some cities across the world have used strategies, for example, such as neighborhood budgeting, where the government gives the neighborhood a certain amount of money to implement programs or to create resources that are important for the neighborhood. And those ideas and resources end up being controlled by the neighborhood. And residents determine how that budget is spent. So there are opportunities, I think, to improve areas and to allow residents to get involved in the decision-making about what neighborhoods need. It doesn't solve the problems, obviously, but I think it helps to improve the local neighborhood situation. And we do need to pay attention to the local environment. There isn't going to be a one-size-fits-all that will work for all neighborhoods.
Right, absolutely. So, of course, we've all been touched by the pandemic over the past 18 months or so. Can you tell us how has the pandemic affected urban health and health equity?
Yeah, we've certainly seen some astonishing statistics emerge during this pandemic, really illustrating the impacts on inequities. In Canada, at the first peak of the pandemic, we really saw catastrophic impacts on some of the Canadian labor force. One of the areas that I study is precarious employment, and there were over 5 million Canadian jobs lost in that first peak. And of course, that wasn't equal. So those who were earning minimum wage or close to minimum wage, more than half of those individuals lost their jobs. Now, if you go up the income ladder to individuals who were making $50 or more an hour, only 1% of those individuals lost their jobs. So you can see that, even among people who were working, that level of inequity existed, caused by the economic impact of COVID-19. And certainly, it didn't just vary by how much you were making an hour. Women bared a disproportionate burden of the pandemic, especially for households that had children with kids at home, not going to school. Women had to do the bulk of that the work, caring for kids and taking care of the school issues, which severely impacted their jobs. Certainly racialized populations and immigrants and precarious workers, as I mentioned, had greater impacts on their economic well-being. You know, at the other end of the spectrum, we've certainly been seeing other astonishing statistics. I think the US billionaires have become 62% richer or something like that during the pandemic. It's, again, another astonishing number. So yes, the inequities have been exacerbated during this time. And I have to say, though, I have been impressed by how governments have been responding and certainly willing to open up the national budget to provide some income buffers and other mitigation strategies to lower the impacts on those with low incomes or who are more precariously employed. In Canada here, we've had the CERB, we've had, you know, eviction moratoriums, we've had paid sick leave, we've had more. Sadly, it doesn't reach everybody equally, so we still see some of those inequities. But also, given how poverty didn't start with the pandemic, it existed before, and so did financial strain among a large proportion of the population. And low income was growing pre-pandemic. Some of these strategies would have been very helpful earlier, even before the pandemic, and I do hope that they are maintained as society reopens. You know, there's some creative strategies being proposed, you know, such as taxing the gains of the rich, which could pay for some of these recovery initiatives. I know they're thinking about that south of the border. So I think we've seen governments behave in ways that we haven't seen them behave in a very, very, very long time. And so it's promising. We know it's possible. I think before what we were hearing is it's not possible to do these things, but we know it's possible now. So it would be nice to see that continue. So we'll be monitoring what happens once society starts to open up.
Bringing you know, some of the ideas you talked about in that response back to some of the earlier questions I was asking, I was thinking, as you said, the impact of the pandemic has exacerbated and increased inequalities, and of course when we think about that, we think lots about the sort of groups that you're talking about, whether it be women, whether it be racialized groups, whether it be all sorts of groups with less resources. And I'm just wondering, to what extent does the urban environment have also differential impact on the well-being and the opportunities for different groups that the sort of groups that you've been talking about? And to what extent do that, again, have those been affected by the pandemic?
Yeah, I think that's a great question. And there's so many answers to that question. So, you know, I think, again, decades of data have shown us that there are some groups that are consistently left behind. And those tend to be immigrant groups or groups that have been historically marginalized and excluded, experience discrimination, some of it formal discrimination. So when I think about, for example, there have been immigration policies that have excluded certain groups, whether it be Asians or Africans or Caribbean, those from the Caribbean. There have been some formal Canadian policies that have excluded those individuals from coming to this country. And then those who are already here also experienced formal discrimination. For example, with the moving Japanese into these exclusion centers, for example, and selling off all of their belongings. And that certainly has an impact and a long-term impact on populations. It isn't just something of the past. We have seen more recently with this pandemic increase and a rise in hate crimes against Asians. So we, for a variety of reasons, a lot of it due to social exclusion, do see ongoing inequalities generated by society against these groups. And so whether it's in the pandemic or whether it's outside of the pandemic, it's something that we need to pay attention to as something that shapes and contributes to inequities.
Okay. So we think a little bit more now about how to improve things. As you said at the beginning, you're very interested in not just studying and understanding these inequities and the health status, but actually trying to develop and work with communities to develop interventions. So how can we improve urban environments and integrate health, social and other services to improve health in those communities?
Yeah. Well, these inequities are not, inherent to cities, even though they have been in existence for a long time, not just decades, but centuries. And they're not inherent to a particular time period, but they are the consequence of human design. And the good news is that since these inequities are created by humans, the urban environment can be reshaped and improved by humans toward reducing those inequities. Our goal should be in reshaping the urban environments and knowing what our goals are and knowing to what extent we want health and social services to be integrated or to be made more accessible. And then with enough political will and resources, we can make that happen. So I think it's possible, but we certainly have some big roadblocks. I mean, this is, of course, very much about power and power sharing and bringing about a desired outcome through the control of what we're calling scarce resources, and also how generous the social safety net is. While understanding and addressing power distributions will determine whether services can improve communities, I often wonder about the role of science. Science is less likely to help with revealing the best solutions in that arena, because the problem is not lack of knowledge, or it's not a problem of logic or even rationality, but instead it is a political fight between different interests. And that's really what we're talking about here. And we're seeing it play out again in the pandemic, where in some ways there's no choice but to help those who have lost their jobs and who are experiencing longstanding health issues. Because if we don't help them now, we're going to create bigger problems for society later. So a lot of this is about different interests and the political fight between those different interests.
Do you see it, and I'm talking of that because you talked a lot about the political situation, and we're seeing particular movements at the moment. Is that creating particular difficulties with the sort of work that you're trying to do and lots of others are trying to do in terms of giving more empowerment to communities to improve their environment and their health?
Yeah, maybe what I'll say is a couple of things about politics and political influences. One is researchers are slow to name that. I think, if you went to communities, they would know, and they've known for decades that, it is about politics. So it's really the science that's probably lagging behind. And some of it has to do with what I mentioned to you earlier, that in the data sets that we typically rely on, we don't have variables like political power and power distribution in those data sets. We tend to have information on individual characteristics. But there is now a recognition within public health and health sciences that we do have to pay attention to politics. And I don't think it presents a problem as much as it does an opportunity for us to talk more about this, because the more we talk about things, the more we can get creative and come up with some solutions. And so I'm optimistic that by beginning to talk about this and name it, and really recognizing that part of the social determinants of health includes the political determinants of health, that we need to start talking more explicitly about it.
So, and just building on that idea, I think it's a very interesting idea. So to what extent then in your experience, do local communities and other groups that you've been working with actually use the data? I mean, if they already understand the problems that they themselves are living, and they already have some pretty good ideas about what sort of solutions could help them, do they use data? Do they need the data? How? I mean, you talked about the politics, and we need to name that and be much more cognizant of that in our world, in academia. But again, going back to, do they need the science as well?
I think so, but let's remember that not all science is created equally. You know, the way I was taught science was for me to look in the literature and then find out what the gaps are in the literature, and then I would design my next study to fill that gap. Well, I can tell you, communities rarely use that information. I think a lot of my work is in fact partnered with community, and they know what the gaps are for themselves. They know what evidence they need in order to advocate for a certain strategy or resource. So they name the gaps. I usually pay attention to the gaps that they name, and then together we do the research, or we do research in response to the gaps that they have named. And usually that information can be used to advocate for certain resources, or it can be used to identify how we can identify new interventions, or what that new intervention can look like. So I would say the answer is yes, communities do use evidence, and they use evidence really to focus on solutions.
Right. Okay, excellent. Thank you very much. So shifting a little bit, can you give us a bit of an overview of the state of science of urban health? What are some of the challenges scientists need to overcome if they are to have strong science informing the design of effective solutions for urban settings?
As I mentioned before, there's a lot of complexity in urban health because of the many different factors that determine urban health or urban health inequities, and the dynamic nature of the urban kind of cross-sectoral processes that interact with each other. We've certainly come a long way in beginning to understand that complexity, thanks to some recent developments in modeling complex dynamic relationships in cities. You know, AI, artificial intelligence, is something that is increasingly being suggested as an important tool in this area. Now, it's not my area of expertise, so I don't want to comment on whether, either way, whether AI will help us to address challenging urban health issues. But some people are suggesting that it is a promising tool. But taken together, if we think about the bulk of the evidence and science that's been generated around urban health, that type of science can be labeled, you know, understanding the problems or problem description. How big is the problem? What are the contributors to the problem? How is this problem related to other problems, and who's most affected? So urban health is very focused on problem description, and that can be contrasted with solution science, where we design solutions to solve or mitigate problems. We might design and evaluate policies or programs. And while we often think that we have to do brand new things to solve these complex issues, in fact, we can do a lot more with evaluations of existing policies and maybe identify some programs that are functioning suboptimally now and not meeting their intended targets. And then we can stop funding those programs that are not working as intended, or, you know, fix those programs so that they start to meet their targets. Now, this latter type of science, the solution science, is something we need to do more of in urban health. If we were to take all of the urban health research, we'd find that about 80, maybe even 90% is problem description, and only about 10% is solution science. So I certainly got into public health research, and I hear from my own students that they're interested in public health science to solve problems and not just to describe them. And so I think we need a shift to in the state of the science on urban health toward more solution science. Of the two, solution science is probably messier and harder. However, this type of science is the only way we get to generate effective solutions. One way that, or one reason why solution science is messy is that we're working to design strong interventions. And it can be a complicated process, especially if you're doing so in partnership with others. But to make it even messier, it's not only important to know what components of a program or policy make it most effective, it's also important to use evaluation skills and to guide strong implementation of program or policy. You know, more than 80% of programs experience some type of implementation failure, small or big. And when a failure is small, it may not make that much of a difference to the overall success of the program, but some implementation failures are very large. And that means that the population being served by that program doesn't actually benefit for the program, or they're not receiving the program that they were intended to receive. And so we need to focus a lot more on implementation support. And again, it's very messy, but if it's not done, then we have a lot of programs that are not meeting their intended target.
So if I understand correctly, what you're talking about, you know, when you're talking about the solution science is you know, getting involved in the real messy world with the communities, and then of course you get, there's the whole, you know, there's a whole range of different sorts of interventions at different sorts of levels. Where, you know, we've talked a lot about the local community, where we talked about the physical environment and the idea of the how local communities are able to try to help themselves. But then, of course, there's things that you need to go up to the municipal, the city level, the municipal level, and the provincial level, et cetera, and that gets even more messy politically speaking. And to what extent, you know, should we be getting involved with that sort of thing as well?
We should evaluate everything is one answer.
Right.
And, you know, should we, I mean, there's sort of a debate within evaluation. Should we let programs evaluate themselves? So should we let politicians evaluate their own policies? Not that they would, but, you know, is that something we should allow them to do? I mean, I do think that there are ethical ways to be an internal evaluator. And so I wouldn't say no, but it might be interesting to give more people evaluation skills so that they can do more evaluation. In fact, something that I've been engaged in, not during COVID, but, you know, for 5 years before that, is I taught a free course on evaluation and evaluation skills to residents of one of the neighborhoods around the hospital. It's a low-income neighborhood. And to be honest, I didn't know who would be interested. In fact, I thought maybe only one person would show up, but it's standing room only, and there's always a long waiting list. And people are interested in learning how to evaluate, and they want to evaluate city programs. They want to do their own evaluations. They don't necessarily trust the evaluations that are coming out of the city for some of the programs that are affecting their own neighborhood. So why not give more people evaluation skills so that they can do evaluation?
Absolutely, that's really participative research. That's fantastic. Changing tack again a little bit, on the U of T website, it states that you use a range of methodological approaches, and I think you touched on a number of them here, and that you draw from a realist philosophy of science. What do you mean by that?
Well, we've talked about the complexity of the field, and it is important for scientists to be familiar with and use multiple scientific tools for the study of urban health. I'm talking about more than just using both, you know, quantitative and qualitative data. Rather, we need to mobilize the right tools to answer the myriad questions that we need to answer to generate these interventions which will improve urban health. I've already mentioned that we need to draw from multiple disciplines to gain a comprehensive understanding of urban health. And, here's where cross-disciplinary or even transdisciplinary approaches are good strategies. But sometimes we have to go even deeper and consider where we are situated in terms of our philosophy of science. It's underpinning our work. So I was trained as an epidemiologist, and when I was trained as an epidemiologist, I was trained to adopt a positivist philosophy of science to do my research. And positivism is the philosophical theory that claims that we can know what is real, what is true, if we can measure it and verify it through observation and experiments and other types of usually quantitative research approaches. Now, there are other philosophies that contrast with that view that don't adopt the view that if you can measure it, it's true or real. And one of those alternate philosophies is realism. Realism is a philosophy that there is a world that's independent from us and what we're able to measure with our research tools. Realism acknowledges that we're imperfect at capturing the real world with our research tools, but we can try to measure it with our research tools and improve our explanations and understanding of the world as we advance our science. So for me, I think realism, more than positivism, is aligned with how I see the role of science in the world. And there are, of course, other philosophies that scientists use, which we won't go into here because that's a whole other topic. And I want to stay close to the question that you posed about realism. I find that realism in my work is particularly useful for understanding and building theory about how interventions work and who they work for and how they bring about change. One piece of the urban health puzzle that is in short supply is the theory of how the social determinants of health cause health inequities and also how policies and programs mitigate those health inequities. So realist research is very useful for that area of research.
Thank you very much. So I want to follow up on with that because it struck me the way you were describing your approach and knowing that you work a lot with the communities that you're studying, but studying is not the word, but working with. So to what extent there are lots of communities out there that have really different views of the world. And I presume therein they have different views of how to investigate the world and different views of science. To what extent have you had experience of communities saying to you, well, we view it, we want to do our research with you in a different way? To what extent are they sort of driving it in a completely, but quite different way, let's say, than the way that you would be planning or expecting to do it if you were running it?
Yeah. Well, one reason to be well-versed with multiple research tools and ways of doing research is that in some ways you can offer up a menu to your community partners or hear what they want to do and then be familiar with how they want to do research. But yes, I would have to say that communities are very clear about what they like and don't like about research. There are some communities which, as we know, have been harmed by research, and so we have to be very careful about research that we do. We want to be very ethical and maybe extra ethical as we do research with communities. Certainly, I've had community partners do what I would call evaluation on certain programs, but they don't want to call it evaluation. I think they've had bad experiences with evaluation. In fact, some evaluators have given evaluation a bad name. When you go into or when you try and evaluate a program and you're just giving it a grade and you don't know much about the context and you're an external evaluator. So I think those can bring more harm than good. And so, yes, I think we really have to take our cues from community about what they're comfortable with. And they do make it clear about what they do and don't want to do in terms of research.
And building on that sort of question, as I said, you have worked with communities to develop interventions. So what sort of interventions have you been working on, and how have you been evaluating them, and with which sort of groups in the community have you been working?
Yeah. Wow. That's a long question, or my answers could be long. So my Canada Research Chair is about population health interventions, that is designing and evaluating policies and programs and interventions to improve health and reduce inequities. So I am trained as a scientist, and I don't necessarily have the skills to design policies and interventions. Rather, I use applied research methods and evaluation expertise to generate evidence to inform their design, or I support, community experts to design interventions by mobilizing relevant evidence. I do co-design, because I think that programs are stronger when you bring the affected populations to the table, because they know what's accepted in the community. So I worked on a variety of programs and policies. So I've done infant mortality prevention programs. I've done that with both community partners and city program planners. In that particular instance, we were able to secure a large amount of money over 5 years to essentially put in probably what's more like a poverty prevention program to do infant mortality prevention. Youth violence prevention programs is something that I have worked on as well with community. I've done programs preventing HIV among women, with women who are very low income. I've looked at school readiness programs for low income populations, prevention of partner violence. I've done a number of those initiatives, looking at basic income initiatives. So you can see that it really is a variety of different programs. A lot of them, though, are really focusing on looking at ways that we can strengthen kind of the social safety net to support those populations.
Okay, I just before I move on to other questions, I just want to remind listeners that please do send in your questions to the Q&A box. We have had one question, which is what are the burning research questions in your work? I think you've kind of touched that, but do you want to add anything to what you already said previously?
Yeah. Well, let's see. For me, some burning research questions are, and again, it's a relatively new field, sort of population health interventions and even urban health. And I think that some of the biggest challenges really center around inequities. I think urban health has focused too much on characteristics of individuals in describing inequities, and therefore in thinking about the solutions for inequities. I think we need to do a better job of moving upstream to some of those, WHO categorizes the determinants of health in two categories. They're the intermediary social determinants of health, and those are things at the individual level, like it could be stress, it could be, unsound housing or unaffordable housing, things that are happening to individuals. But then there's the structural determinants of health, which WHO calls really the root causes. And I think the burning questions are around that. How do we do a better job of understanding the role of those structural determinants? And then how do we intervene on those? How do we mobilize evidence to intervene on those structural determinants so we can close the inequities and close the gaps? Because we haven't been able to do that for a long time. The inequities keep growing.
Yeah, absolutely. And on that front, you've talked obviously a lot about social and structural determinants of health, and I'm wondering to what extent you thought about, worked with the concept of the commercial determinants as well. I work in the field of, I'm in dentistry, and there's been in recent years a strong focus on commercial determinants, particularly the sugar industry. And I'm just wondering to what extent that is another element to understanding the issues in urban settings.
Yes, very important. A lot like the political determinants of health. I think that we've ignored those far too long. I would agree with you. The commercial determinants of health are very important to consider, and they very much are very powerful in shaping the well-being of populations. So we do need to do a better job of understanding the commercial determinants of health.
And then find solutions, not just understand the problem. So how can health professionals and health services interact with the community to help improve health and reduce inequalities?
Right. That question might be better posed to a healthcare professional with expertise in the area, but I like this question because you're asking how, two key social determinants of health interact with each other. So much of our science looks at this, independently. How do healthcare affect health, and how does community factors affect health? One way to think about this is to really look at our healthcare models. Some models of healthcare that we have here in Canada, like community health centers, or even one model of primary healthcare like family health teams, they really have built in the possibility of healthcare directly interacting with the community, because these models of healthcare are interprofessional and they have types of providers within the teams or on-site in community health centers whose job it is to make sure that healthcare interacts with community resources and communities in a way that they're all working toward the same goal of supporting patient well-being. And so these models of interprofessional care that include, say, social workers who can reach out to the community and to those who are working in the area or providing services around the social determinants of health, attempt to break down the typical silos that are encountered when services are designed. Those silos often keep healthcare from interacting with community to work together to support patients. So if a particular patient needs housing, they have to go to a whole other building and a whole other area to get help with housing, but this kind of brings this together. Sadly, only a subset of patients actually have access to this type of care, and it's not universal throughout, say, primary care in Canada. But these are the type of models that experts say are best at supporting health. And there certainly is a very interesting background to the establishment of these models that intentionally link healthcare with community, which are worth looking into. Or maybe you can even have a speaker come describe the political journeys of the key players that enabled Canada to kind of implement these models.
Great, thank you very much. We've got a few more questions now in the Q&A box, and one has come in asking about the differences in what you've been talking about in North American settings compared to, for instance, low-income countries. Are the issues, broadly speaking, you've been describing the same or very different?
Yeah, it's a great question. I mean, certainly we can't ignore the fact that low-income countries are in some ways kept low income because of some of the ways in which, the high-income countries go into low-income countries and work with resources, deplete resources, et cetera. So we can't ignore the connection there. They are not independent. Low-income countries and high-income countries are not independent. But in terms of cities and what's important for cities, I think many cities are facing similar issues. There was a kind of a tool or a process that was developed by the WHO a little over a decade ago, and it was a follow-up to their landmark report on closing the gap about closing health inequities all over the world. And this strategy, it was called Urban HEART. HEART stands for Health Equity Assessment and Response Tool, was an approach designed to respond to documented health inequities. And that tool could be used, all over the world. And it was very helpful in helping people to focus, or helping champions and politicians focus on really responding with evidence-based strategies to the inequities that they document in cities. So I think there's a lot of commonalities.
Great. There, I'm just looking at the time. We've only got a couple of minutes left, but there's another couple of questions. I'm gonna, if you could just remember, we've only got a couple of minutes, but one question coming in says, do you make distinctions in your approach if you want to research? Do you make distinctions between facts and values? To what extent can research clarify what we should want to achieve as opposed to what the likely impact of particular policies would be?
Yes, we do need to make distinctions between facts and values. I mean, I think you might even interpret facts differently depending on what your values are. And I think that's a really important point to bring up, that we need to be very clear and explicit about our values. And I'm definitely not a libertarian, but thank you for bringing up that point, because I think it's very, very important.
Okay, thank you very much, Pat. So I know there are a couple of other questions coming up, but unfortunately we've run out of time. And I just want to say a really big thank you to you, Pat. It's been a really fascinating discussion. Speaking for myself, I've learned a lot. It's made me think about things in a different way, and I've really, really enjoyed the discussion. So thank you so much for taking the time to be with us today and talk with the other fellows.
Thank you, Paul. It was very fun.
Great. Okay. And so now I'm going to hand back to you, Siobhan, to say the few final words before we leave.
Thank you very much. I'd just like to echo Paul's remarks, and thanks. It was a terrific discussion and incredibly timely. Just before everybody signs off, I'd like to remind people that September is a very busy month for the Academy. We've got the AGM on the 13th. And forum on the 28th and 29th. So if you haven't registered, please do. And then these dialogues will resume again following September. The third session will be feature Dr. Jan Sargent, who's professor at the University of Guelph and a leading expert on zoonotic disease and public health. And she'll be in discussion with her colleague and board member, Dr. Jay Cross. And so be sure to join us. They'll be talking about pandemics and zoonoses, misinformation, and what we know so far about the animal origins of COVID-19. So looking forward to seeing everybody when we resume in the fall. And thank you all for attending and making it here on the last day of August. Thank you very much.